Thank you for joining us today for our webinar, Breast Health, Understanding Your Screening Options. My name is Sherry Cordery, and I'm the moderator for the program today. Before we begin, there are a few housekeeping notes and instructions. I'd like to start with the disclaimer. The information presented today is not intended to diagnose, provide treatment options, or replace the advice and the care of your healthcare team. Please seek out medical advice and medical care and advice from your healthcare team as it pertains to your individual situation, and do not delay care. We have some additional instructions that this program is being recorded. All attendees are muted for the duration of the program. Attendees will not appear on video. A question and answer session will be held at the end utilizing submitted questions, and questions can be submitted throughout the program utilizing the Q&A feature at the bottom of your screen. Please do not submit any questions containing personal health information. For the program today, we will be discussing breast cancer screening guidelines, different types of screening, dense breasts, considerations for high-risk populations, and COVID vaccine considerations. And now I'd like to introduce our presenter today. Dr. Anna Mazor is a breast surgeon with Redeemer Health in partnership with MD Anderson Cancer Center at Cooper. She is a fellowship trained in breast surgery and has been with Redeemer Health for over 4 years. She is also a Philadelphia native. Please welcome Dr. Anna Mazor. Please take it away.
Hi, everyone. I'm so happy to be here. Thank you for allowing me to take some of your time to talk about really important screening recommendations today. So I'm going to just be highlighting here some recommendations about general screening for the average person. There are a number of professional societies whose recommendations differ just slightly, and I'm not going to get into all of the different recommendations, but in general, when we screen breast cancer on a regular basis, we can catch it early before it is felt and thereby save lives. If you are in the ages of 25 to 39 and you're of average risk, meaning you don't have a strong family history, you don't have a hereditary cancer mutation, then we generally recommend getting a clinical breast exam every 1 to 3 years by your physician, either your GYN or your primary care physician. Starting at age 40, and again, some recommendations start later, we recommend getting a mammogram every year in addition to a clinical breast exam every year. Women who are at higher risk, however, might need to alter these recommendations just slightly. So what happens at your clinical breast exam and what can you expect? Generally, you're going to be asked a number of questions regarding your reproductive health, including the age of your first period, the number of pregnancies you've had, when your first pregnancy occurred, when menopause started, all to get a feel of your lifetime exposure to hormones. We would also ask you about any changes that you've noticed in your breast yourself. And then you will have an exam where your breasts are examined, changes in your skin or nipples will be checked, any masses, looking for any masses or lumps under your arms. And it's usually a pretty thorough exam. Now, just to give you a review of what a mammogram is like and what to expect. So mammogram is a very, very low dose X-ray, and it's used to find tumors before we can feel them. In general, a tumor in the breast can only be felt once it's about 1.5 to 2 centimeters in size. And it's important to find them early and small so that we can treat them in a very expeditious fashion. So mammograms are performed, by specially trained technicians to get pictures of the breast. You're put into a compression and very low dose x-rays are taken. This machine to the right of the screen is what you would expect to see. And then once the x-rays are taken, they're uploaded, and a radiologist, usually who's specially trained to look at mammograms, will check your mammogram pictures, and it's usually a couple views from each breast, and then send a report to your primary or your GYN. Either you've had a great exam and it's normal and you just come back in a year, or if they find something of concern, you may be called back for additional imaging to look closer. So at Redeemer Health, all of our mammograms are 3D mammograms, and this is an important distinction. Standard digital mammography has largely been replaced by 3D since about 2011. And this involves creating very thin sections of the breast, millimeter at a time, to create a 3D reconstruction so that we can see through the breast tissue and perhaps find lesions that might be masked by overlapping breasts, especially in dense breasts. And what we found is that 3D mammogram does improve our cancer detection rates in women who have dense breasts. And it's currently the preferred modality and does not increase the exposure to radiation. Overall, screening mammogram does decrease the mortality or deaths from breast cancer. Another screening modality that we have is something called automated whole breast ultrasound. And this is a technology which averages the volume of the breast and reconstructs the breast in a 3D image as well to try to see through dense tissue. It takes 15 to 20 minutes to complete, and it does not utilize X-ray as opposed to mammogram, which does. It is another non-invasive way of trying to find small cancers that might be hidden within dense tissue, but is only really appropriate for women who are considered dense. And we'll get into that in a minute. MRI is another screening technology which we have, and it also does not use radiation. This is a very high strength magnet, which causes changes in the particles in our breast and the water and the fat. And with the help of a contrast, can highlight any areas where there might be blood flow related to tumor growth. It images both breasts at once, and again is a very sensitive test and can look through dense breast tissue, but has some drawbacks. One of those being that you need to inject this dye, and dye has some contraindications, meaning you can't use it in those who have kidney failure, anybody who is pregnant, and people with a significant dye allergy. There is an FDA warning on gadolinium agents because they've been shown to accumulate in the brain. However, we don't know that it causes any harm. We just have found it on autopsies. And so newer agents were made to be less accumulating and be excreted by the kidneys. Another drawback to MRI is that it's very costly and has a high false positive rate, meaning you will be called back for more benign things that may appear suspicious. It also needs to be scheduled around the menstrual cycle because your menstrual cycle can impact the appearance of your breast on MRI. And individuals who have a history of exposure to shrapnel are not able to undergo MRI screening. It is good for other things as well as screening. So we can assess any breast implants for their integrity to look for a rupture. We also use it in newly diagnosed breast cancers to look for a breast cancer on the other side, or breast cancer that might be in multiple areas of the breast. It's also used for high-risk individuals as an adjunct or an additional screening method. It's important to note, though, that MRI has not shown to improve survival in anybody, not even in high-risk individuals, but it does find smaller cancers that could be detected in between yearly mammograms. Just a little note, anybody who has had a history of chest radiation for a mantle lymphoma might also require this kind of screening. We'll talk about that a little bit in a second. So what does having dense breasts actually mean? Well, the breasts are made up of skin, fat, connective tissue, and dense glandular tissue. The fibroglandular tissue is the area where there are um, ducts and lobules, and that's the hormonally sensitive parts of the breast that during pregnancy and lactation create milk. Women usually fall into one of 4 categories of breast density, and this is entirely genetic, and you have very little control over this. The majority of women are in category B and C density, which can be seen here. And then some women, very rarely though, are category A, which means that their breasts are mostly entirely fatty, very little glandular tissue, and x-rays easily penetrate them, versus extremely dense tissue, which you can see here, where it's mostly white on mammogram because the x-rays are not able to penetrate through this tissue. And as you can see down here, only 10% of women fall on either end of the spectrum, and everybody else falls right in between. This is a little bit subjective, especially the difference between category B and C, and depending on one year to the other. Some years you may fall in the B category, depending on who's reading your mammogram, and some years you may fall into the C category. So since about 2019, there have been laws passed in 36 states, and Pennsylvania is one of them, requiring that patients be notified on their breast density. And you may see this disclaimer at the end of your mammogram report. You are noted to have dense breasts, and this may put you at slightly higher risk of breast cancer and decrease the detection rate. And what we found is that for whatever reason, the having dense breasts means that you have a greater proportion of your breast that's made out of that glandular tissue and less of fat, and that increases your risk of breast cancer, maybe 4 to 6-fold. It's usually genetic, so it could be that if your mother or your sister or your aunt has this type of density, you may as well. Our breasts, however, sometimes can get less dense over time. That could be due to aging and other medications, such as those that we treat cancer with, like tamoxifen. So we tend to want to screen dense breasts slightly differently. A number of societies recommend starting the 3D mammogram at age 40 and continue it until you remain in good health and your life expectancy is greater than 10 years. And that's for all screening, really. But for women with dense breasts, we recommend having another supplemental test like an MRI or an automated breast ultrasound in addition to mammogram. And really, those who qualify for MRI may or may not be covered by insurance, and it really depends on your insurance carrier and your risk. These tests, automated breast ultrasound and MRI, do not replace mammogram, but are to be done in other intervals, either at the time of mammography or 6 months from the time of mammography. Women who have a history of breast cancer, who are also considered dense, should get 3D mammograms for at least, diagnostic mammograms for at least the first 5 years, and also consider MRI yearly. And women who are higher risk, and we'll talk a little bit more about that in a minute, also should be getting MRI yearly, and they may start MRIs at a younger age at 25 and mammogram at age 30. There's a number of different ways that we can determine your risk, and really your healthcare provider should be the one to help you with that. There are risk models which we can put in your information and come out with a number to estimate what your lifetime risk of breast cancer is. Most of these involve taking a history of first or second degree family members that have cancer, whether or not you've had mantle radiation or lymphoma, a BRCA mutation, which are all considered high risk. And then there are individuals who have a history of atypical lesions in the breast or lobular carcinoma in situ, which are also at slightly higher risk of breast cancer. Anyone with a history of breast cancer is considered intermediate risk, so not above that 20% range, but slightly higher, and that's why we recommend considering MRI if they're as dense as well. And then those individuals that are greater than 20% from other factors, usually it's because you have one or two first-degree family members, have not had children or have taken hormone replacement or have had a lot of biopsies, may be determined to be higher risk for breast cancer. So if you think you fall into any of these categories, this is something that you should consider talking to your provider about, whether it be your GYN or your family doctor, to look at if supplemental screening is right for you. Just some considerations when talking about COVID vaccination. So as women were getting vaccinated, and individuals in general, we were noticing that there was slight swelling of the lymph nodes and tenderness on the side where they were getting the vaccines. This was seen in both the Pfizer and Moderna vaccines, though more reported in Moderna, and very, very, very common in younger patients. We were seeing on mammogram a lot of these incidentally swollen lymph nodes, especially within 4 to 6 weeks of their COVID vaccination. And so we came out with recommendations based on this. Really, mammograms should be performed prior to vaccination or 4 to 6 weeks after the second dose. But this was only for screening mammograms that were yearly screening. If there was a diagnostic that you needed because of an issue that you were following, you were not supposed to, you are or were not supposed to delay your screening or your imaging. Women with a history of breast cancer, we recommend getting the vaccine on the opposite side of the breast cancer so as not to confuse the picture and cause swelling in the lymph nodes that was really not significant. And also to decrease the swelling and inflammation on that side. Or prevent it. And when talking about, just a note about talking about patients who actively have cancer, the American Cancer Society and the American College of Surgeons recommended that anybody who is undergoing active cancer treatment should still get the vaccine regardless of the timing of their treatment, whether or not they were getting chemotherapy, radiation, immunotherapy, or if they had surgery. And although there are no studies, there really are no safety concerns. So that's all I have. I guess we can get to questions.
Thank you. Thank you, Dr. Mazor. At this time, we will open it up to question and answers. Some things to remember for this time frame. Go to the next slide. So please submit your questions utilizing the Q&A feature down at the bottom of the screen. And we are opening for questions. First, I'm going to start with one that came in during the program. Do women who have had a mastectomy need to get a mammogram?
So that depends. In general, if a woman has had mastectomies on both sides, there's no current recommendation for any imaging for screening. However, if they've only had a mastectomy on one side, then they should continue mammography on the other breast and or MRI if they fall into that category of dense breasts.
Thank you. Is a breast MRI better than a full breast ultrasound along with mammogram?
So no, I mean, one cannot, as I said, one cannot replace the other. MRI is just another type of test that we in our toolbox to use to try to find lesions that might be hidden in either dense breasts or women who are at elevated risk. It's not better than one. It is a very, very sensitive test, as I've stated, but that increases the rate of finding benign things. Mammogram and ultrasound and MRI are all used in different circumstances, but mammogram is the only one of those studies who's been shown to improve survival in women.
Thank you. I have a family history of breast cancer. How do I get tested for the breast cancer gene?
So that's a very good question. Most of the GYNs and family doctors in the area should be able to either risk stratify you and determine if genetic testing is appropriate or refer you to a genetic counselor. So I would talk to either your family doctor or your GYN to see if they are comfortable performing genetic testing or referring you to a genetic counselor.
Thank you. In a previous screen, I had 2 cysts, and a follow-up years later, I didn't have any cysts. Is it possible they disappeared?
So in general, cysts are something that can wax and wane. It isn't necessarily something that would show up on every mammogram for years to come, although somebody who has cysts may get different cysts at different times.
Okay. We have a couple of additional live questions here. Does IVF cause an increased risk of breast cancer?
So I don't think we have any strong evidence to point to that, because I just don't think it's been studied well yet. And IVF is much more common now than it was in the past. I'm sure that's a question that we are going to ask, and we are asking. It probably has some additional hormonal exposure, but I can't say for sure that it increases your risk of breast cancer.
Thank you. I have 2 sisters who have had breast cancer. Should I get a specific type of screening done?
So I would talk to your GYN. Again, your individual risk needs to be assessed based on your family history and your other personal history. It may be appropriate for you to have additional screening, but again, that depends on your breast density. It depends on your other risk factors, whether you've had biopsies before. So I would talk to your GYN about that.
I have dense breast tissue. Should I be concerned if I'm asked to have additional screening testing done after my routine mammogram?
Well, I know everyone gets concerned if they're called back. That's very, very stressful. And it's very common if somebody has dense breast that they need to be called back to look with more diagnostic or in-depth imaging. You know, can I say don't be concerned? No, because we don't know what we're going to find. Screening is a way to determine if you need any more in-depth imaging. And if you need to be called back, I would wait for what the results of that show. If there's ever a question, you should call your doctor, and you can always seek the help of a breast specialist as well.
Okay. How long would you consider too long to have lumps in the lymph nodes after a COVID-19 vaccine?
So say this again, lumps in the lymph.
How long would you consider too long to have a lump in a lymph node after the COVID-19 vaccine?
Well, we really expect the lymph nodes to return to normal after about at least 8 to 12 weeks. So if after 12 weeks it's persisting, that's something that I would get checked out.
Yep. Are microcalcifications typical, common, normal in dense breasts?
Microcalcifications are sometimes normal and sometimes not. Generally, if that is something that's seen on mammogram and hasn't changed, you know, it may be normal. It just depends on what the other features of them are. So calcifications can be normal in the breast, but it depends on their distribution, how long they've been there. So that I can't answer that completely. Yeah.
Can you talk a little bit about preventive measures for those at high risk?
So that's like an entire other talk that we're hopefully going to be giving in the future. I think in general, the big things that I'll say really quickly are not smoking, not drinking alcohol, maintaining a healthy weight and body mass index, with a good diet and regular exercise in general.
Mhm. How well can you feel a lump if it's small, and what do lumps feel like?
Yeah, so again, it's really hard to feel a lump in the breast if it's under 1.5 to 2 centimeters. And that depends on your own, breast tissue. Suspicious lumps are in general firm, fixed, irregular, not smooth. But if you ever find a lump and you ever have a question about a lump in your breast, you should immediately contact your physician.
Mhm. Mhm. I'm trying to see. We do have some other questions here, but a lot of them are kind of, very personally targeted. So I'm not sure that I'm trying to think if there's a way that we can say these in a general way. Um, cystic tissue. I think that is it. There's a couple others. If they fall into breast density category D and have cystic tissue, but my OBGYN did not recommend further testing, should I ask for further testing?
I mean, that could actually be very appropriate.
Mhm. Yeah.
Yeah.
Okay, I think those are all the questions that we have so far. Let's see if anything else has come in. Oh, here's some. What about a benign tumor should raise concern?
So that's a very general question. More specifically, so there are benign tumors that are just that, benign, and we don't worry about them. But there are features of benign tumors that are more concerning. It just depends on the tumor.
Mhm. Right. Um, at what age should a woman get a baseline mammogram?
Again, really, in general, average risk women, it's 40.
What does increase the reoccurrence of breast cancer?
So those lifestyle factors that we talked about, in general, do increase those risk factors. So, not maintaining a healthy weight, being overweight or obese, smoking, consuming alcohol, those things can all increase recurrence risk.
Can dense tissue sometimes feel like it's a lump?
Certainly. It happens all the time. Yeah. That's what imaging is for, to help discern that.
Does the breast center see patients that have a high risk of developing breast cancer?
Yes, we do. We actually have a high risk clinic. We call it a clinic. It's in the same facility, that's run by our nurse practitioners, and that's really what they do is they screen and do breast exams and provide the appropriate imaging based on an individual's risk. So yeah, we see a lot of women who are high risk.
Okay, great. All right, I think those are all of our questions for the evening. I think that thank you very much for all of your time today.
My pleasure.
And could be on the next slide. So thank you everybody for joining us. If we did not get to your question, we did have quite a few that came in with personal health information. So we will be able to, if you'd like to, email us and we can connect you with the physician directly, some information so that we can get your questions answered. Thank you for joining us today, and we hope you have a wonderful evening.